Hello and welcome, and thank you for joining our live stream. We're here with Dr. Jon Henry, Dr. Carl DiRaimondo, and Dr. Craig Olson. All three doctors are orthopedic surgeons with orthopedics and sports medicine BayCare Clinic in Manitowoc. Today we're focusing on partial knee replacement and total knee replacement. Dr. Henry is a board certified in orthopedic surgery and in sports medicine by the American Board of Orthopedic Surgery. He is fellowship trained in sports medicine. Dr. DiRaimondo is board certified in orthopedic surgery and in sports medicine by the American Board of Orthopedic Surgery. He's also fellowship trained in sports medicine. And Dr. Olson is board certified in orthopedic surgery by the American Board of Orthopedic Surgery. He is fellowship trained in shoulder and in sports medicine. Thank you all for joining us.
Thank you.
Visit our website for more information on the doctors' backgrounds. But before we get started, we'd like to invite you, our viewers, to feel free to ask any knee-related questions in the comments section. We'll do our best to answer your questions in real time, but if we don't fret. We will answer those questions at the conclusion of this live stream. So hearing that, let's sort of just get right into it, gentlemen. We're talking today about knee replacement surgery. Many of us have undoubtedly heard about knee replacement surgery, but I'm betting not a lot of us know exactly what that entails. Hopefully you can explain that for us today. Let's start with Dr. Henry. Can you help explain in very basic terms, what is knee replacement surgery?
Sure, glad to help out. And I think it's important to understand knee replacement is generally performed in a situation where the cartilage in the knee is damaged beyond repair. So it's a salvage procedure, most commonly performed for osteoarthritis, sometimes for other types of arthritis like rheumatoid, far less commonly for a post-traumatic condition. So with osteoarthritis, the most common situation, that's where that articular cartilage, the Teflon coating on the thigh bone, shin bone, and the back of the kneecap gets worn out, kind of like losing the Teflon on your pots and pans. And when it's damaged beyond repair and the individual has continued symptoms that are compromising quality of life, then it's time to trade in the old knee for a new one. That's where knee replacement comes in. And the procedure, just kind of in the simplest sense, is removing the damaged cartilage and replacing it with an artificial components, like resurfacing with new parts.
Okay, so there are many knee replacement procedures available to patients, but we're focusing on two types, partial and total knee replacement. We're sticking with you, Dr. Henry. Can you explain to us what is partial knee replacement surgery?
Yeah, this is where I'll have some maybe useful or insightful input here, because I don't do total knee replacements. My practice or expertise is more in the realm of joint preservation, but I do a particular type of partial replacement, patellofemoral replacement or arthroplasty. So I think I can lend some help here, but Drs. DiRaimondo and Olson will give you more expert information on that.
Absolutely.
So think of the knee as having different compartments. Between the thigh bone, shin bone, there are two parts, medial, lateral, medial on the inside, lateral on the outside. Those are two separate compartments. And then the third compartment is the kneecap joint or patellofemoral. So each of those three compartments can be replaced individually. That's a partial replacement. If you replace all three compartments, then it's a total knee, generally speaking.
Okay. So when is partial knee replacement a strong consideration?
Most commonly, again, for osteoarthritis, when that one compartment of the knee has end-stage damage beyond repair, combined with long-term unacceptable symptoms that are compromising quality of life, with failure of lesser options like therapy, bracing, anti-inflammatory medication, possibly cortisone, possibly lubrication shots. There's a laundry list of options short of surgery to consider to compensate. When all else fails, then surgery. And if that damage is isolated to one compartment, like in the situation that I use or perform patellofemoral arthroplasty, if the kneecap is just worn out beyond repair, then you can resurface it. That's where partial replacement comes into play.
Okay. So if a patient is scheduled for this type of surgery, how do you instruct them to prepare? How should they prepare for this type of surgical procedure?
Well, and again, like, as I alluded to, surgery, in this case, a partial, but even for a total replacement, it's generally last resort when lesser options have failed to provide enough relief or restored acceptable quality of life. And there is a preparation process. The patient needs to be medically optimized if they have any underlying medical problems, especially things like diabetes or high blood pressure, heart disease. Those things need to be sorted out and optimized prior to surgery. That's where we work with the primary care provider in that process. There's a lot of education involved through our office. We want patients to be fully aware of what they're getting into. They know what's involved with the surgery and the recovery and the rehab. A lot of times we will use our physical therapy colleagues to help prepare patients for the rehabilitation process. Sometimes some therapy before surgery can be helpful to work on strengthening the muscles around the joint. That can really help to optimize the rehab process afterwards. Sometimes there could be some pain management techniques that are useful before and or after surgery to minimize pain. We'll use different techniques, sometimes use some of our pain management colleagues. So it's a kind of a multifaceted process.
Right.
That the preparation is very important for the goal of minimizing any chance of complications from or after surgery, but ultimately to give the patients the best chance for success, which we define as restored quality of life.
Okay. Talk briefly about any post-surgical care with partial knee replacement surgery.
Yeah, it'd be similar to total knee, although generally a partial replacement is less invasive and therefore somewhat less involved post-operatively compared to a total knee replacement. But usually there's some temporary bracing, definitely some physical therapy, pain management techniques, whether that's with blocks or medication. We've learned over the years that we can use different medication, not always narcotics, to help manage pain and optimize recovery. So again, it's a team approach. It's not just a surgery, then the patient's good to go. It's a surgery, then really dedicated, skilled rehabilitation, pain management, and just guidance through the post-operative process. But generally with a partial, as with total knee replacement, patients can fully weight bear. They can work on getting their motion back. There aren't any set restrictions. It's just more a gradual progression of activities and exercises.
Okay, thank you so much. Dr. DiRaimondo, you're up. Kind of piggybacking off Dr. Henry and post-surgical care with the partial knee replacement, talk a little bit about the importance of rehabilitation or physical therapy. Is that really needed, or is that kind of a case by case?
So, I mean, anyone who's had a knee surgery, and obviously we're talking about partial and total knee replacements, rehabilitation or exercises are critical to success. The majority of that will be the patient doing them themselves at home, having some form of guidance, depending on the level of impairment and weakness and what have you going into surgery. Most benefit from having some touch points with a physical therapist, whether that's at home, whether that's possibly going to a therapy clinic. There are a lot of programs now where, you know, as Dr. Henry alluded to, we're doing prehab. We have patients seen prior to. They're educated on many of the exercises they need to do after surgery. You know, a lot of, you know, with more modern technologies, there's apps and other things that people can be checked by their therapist. I tell patients from the time they get up to the time they go to bed, they're in constant rehab. You know, when they're going through these first few weeks, when there's more swelling, more stiffness, walk every hour, do your exercises every hour, ice every hour. You know, if they're in that mindset where they're really putting in the effort, those are the patients that will see the quickest turnaround as far as return to quality life, but also the best outcomes long-term.
Okay. Dr. DiRaimondo, are there any restrictions on the surgically treated knee once a patient is cleared by your office?
Well, I mean, that's a great question because you eliminate pain from a patient. They tend to do what they want to do. And it also depends on the level of function. You know, my kind of standard statement to my patients, you can walk, you can hike, you can bike, you can squat, you can kneel. We discourage running and jumping. That's not to say they won't do it. I say if you're getting chased by a bear, run. Lower impact. I mean, understand what we are doing. We're creating a facsimile of a knee. We're not creating a 20-year-old knee. But those patients that end up having partial or total knees are quite debilitated. They can't do much of anything.
Right.
So by eliminating their pain and restoring function, we want them to understand longevity of the replacement. We want this to last 25, 30 years. So it's like any vehicle or any material, treat it right, it'll treat you right. So, that doesn't mean people can't go back and play tennis, they can't go back and ski. I discourage more like, basketball or some of those activities, but also being said, you eliminate pain, patients are going to go back and do what makes them feel well.
Right. So then what physical changes, if any, do people feel once they've had a surgically replaced knee?
Well, it depends, partial versus total. Partial
Right.
implies we're leaving many of the normal anatomic structures in place. As Dr. Henry alluded to, you can replace the kneecap or patellofemoral. You can replace the inside or medial compartment. You can replace the outside or lateral. One of the indications for a partial knee replacement is our intact and normal functioning ligaments. So if you look at somebody after a partial knee, and they've done studies looking at how the patient perceives and feels, it tends to feel more like a normal knee. When we do a total knee replacement, we're recovering all surfaces. We're substituting for some of the major ligaments. It's still better than what they had, but it's probably not quite as, it doesn't feel quite like a normal knee. Now, having said all that, we'll have patients that come in and say, I don't even think about my knee, doctor. So there's a little bit of subjectivity to it.
Okay.
But partial certainly will feel more natural to a patient.
Okay. We're sticking with you, Dr. DiRaimondo. Let's switch gears and talk about total knee replacement surgery. Can you explain what total knee replacement surgery is?
So Dr. Henry kind of alluded to, and we all have our analogies. I tend to refer to the surface cartilage as treads on a tire versus Teflon, but they all mean the same thing. When the treads on the tire wear out, and if we're talking about a knee that has 3 compartments, if 2 or more of those compartments are worn and symptomatic and you fail conservative treatment, ultimately you need to resurface the whole joint. So essentially what a total knee is, we're capping the ends of the bone with metal and plastic. We will eliminate all cartilage or all osteoarthritis. And as I tell patients, it's a cure of the disease. Whether there's any cartilage left, or any cartilage that was still worn, we're eliminating that, including something called the meniscus. So really, in the diagram that you're just placing on the left, that's a total knee. The dark is the metal on the femur and the tibia with a gap in between, which is plastic. On the right, that's a very arthritic appearing knee. But since all compartments are involved, they benefited from a total knee. That's the most powerful operation we can do. And many times when patients come to total knee replacement, there's stiffness, there's bowing one direction or another, they lack motion, there's excess bone blocking motion. And with that operation, we can straighten the joint from the front and side. We can eliminate many of those blocks to motion that allow patients to gain back their function.
So you kind of led into my next question, which is, in what instances do you recommend total knee replacement surgery?
So total knee replacement would be more than one compartment that has, significant osteoarthritis. A knee that might have one compartment, but ligament damage that's not reconstructible. So even if we did a partial, because of that ligament damage, the function would be poor. Certainly in the face of, as Dr. Henry already alluded, these are patients that have already gone through an extensive period of time of non-surgical treatment. And at the end of the day, I tell patients that the decision to have a total knee is theirs. They have to have that little switch in their brain that, at some point it says, no way do I want to do a surgery, to, hey, I'm ready to do that surgery. So then I know they're going to be motivated to follow through and do the exercises afterwards.
Right. So is post-surgical care with partial or total, is it the same thing? Or is post-surgical care different depending on what procedure you undergo?
No, I mean, the approach is similar. I mean, it's all about those first several weeks and dedication by the patient to do their exercises. As it's been mentioned, a partial knee, meaning we're only involving one portion of the knee, is less overall invasive. Typically, they tend to have less swelling, less pain, so they can run about a week or two faster than a total knee. So they tend to get back to their normal activities or their their recoveries a little bit faster. But it doesn't change the fact that it's still, you got to put the work in and you got to do the exercises.
Right. And then last question for you, at least for a little bit. How soon can a patient expect to return to normal activity after undergoing a knee replacement
So
procedure?
my general rule of thumb that I tell patients, and certainly motivated patients can beat this standard. Usually they're on a walker for the first week or two, then a cane. Within 4 to 6 weeks, they're off a cane.
Okay.
So by 6 weeks out, they're probably 60, maybe 70% recovered.
Okay.
By 12 weeks, they're 90% recovered, and little things can heal out to a year. But within a 2 to 3 month period of time, if they're motivated, they're back doing things they haven't done in years, whether that's work or recreation, provided they put the time and effort into the therapy.
Okay, thank you so much. Dr. Olson, thank you for waiting patiently. Let's discuss how common these knee procedures are. I mean, how often are you seeing and treating patients with knee issues that likely will result in a total or partial knee procedure?
Yeah, very good question, because I think we see several patients every day that are surgical candidates, 5, sometimes 8 in a day. But the key thing, and I think Carl, Dr. DiRaimondo mentioned, patients have to be ready to go forward with this. I mean, we see joints that are far gone, that you're just saying, boy, I could fix that right now and make that patient feel better. But I think one of the most important factors is patients being ready to move forward and commit to what needs to be done. A lot of things in 5 years have changed quite a bit. We educate our patients more. The pre-rehab that's been brought up before, the medical optimization,
Sure.
A lot of things have changed, and there's a huge commitment on the patient side to make it very successful. And when they do, it is very successful. So, and we have lots of support in our system with our nurses, our staff, our therapy. We have a great support system, whether it's here in this office and in the hospital, to really help people get through this process. So we see a lot of patients every day.
Well, let's talk about some of those patients. Like, who is your typical patient? Is it the weekend warrior? Is it a guy or gal who just fell off a ladder and cracked his or her knee? I mean, who is your typical knee patient? Or is there a typical knee patient?
I think it's the person with like the 1963 model car that has driven it for decades and has driven it hard, who maybe does, heavy either manufacturing or laboring type work, maybe had some injuries along the way. I mean, a lot of patients we see have, arthroscopic procedures and minor procedures to their knee. And, all of that is really a process of just taking more of the normal structures and, moving down a pathway to a flat tire. Like Dr. DiRaimondo said, the tire goes flat, the patient is suffering. And usually, in my experience, it's usually snowing at night when the tire goes flat. It's never at a good time.
Okay. We actually have a question that came in. Linda is asking, can you just have a kneecap replaced, at least until she's older, for full replacement? So it sounds like she's asking, can you defer a little bit until she's ready for full knee replacement?
Dr. Henry, that's you.
I'll take that. This is within my quote unquote joint preservation realm, which technically it's not joint preservation because we're resurfacing the kneecap joint. But the answer is yes. For patients that have chronic symptomatic kneecap arthritis, where the arthritis is isolated to the kneecap only, that means that everything between the thigh bone, shin bone is okay, that it's functioning well and not causing symptoms. So in that situation, again, when lesser options fail and someone has compromised quality of life, they have to resort to surgery, then kneecap replacement or patellofemoral arthroplasty is a good option. And generally I'm performing these for patients that are a little bit younger than total knee replacement patients. Mm-hmm. And often it can be considered a bridge procedure. that we're going to replace the part that's worn out, save the other parts, knowing that 10, 15, maybe 20 years down the road, if the rest of the knee wears out, then that patellofemoral replacement can be easily converted to a total knee. We're not burning bridges.
Okay. Back to you, Dr. Olson. So when a knee condition is diagnosed and surgery is found to be the best treatment, how do you determine the ideal surgical treatment option? How do you determine this is a partial versus this is a total?
No, it's a difficult question, a great question. Patients just present in a lot of different ways. And, one thing in orthopedics, and all three of us would probably tell you, is that most of our treatments, no matter, what area we're working in, is really customized to patients. And so we just really have to understand, where is the pain source, which is the predominant cause of the problem, and customize. So if one compartment is able to be determined that it's the key driver and that you can verify that the other compartments are okay and look reasonable, then we can kind of approach that with the idea of just replacing the bad part, whether it's a uni-compartmental partial knee, whether it's the inside compartment or outside compartment, or like Dr. Henry was just talking about, the kneecap is the area where the pain is the most problematic, and, address it that way. But one thing that I just should point out, at least Dr. DiRaimondo and myself, our best procedure is a total knee. Why is that? Because that's what we do the most of. So do we do partial knee replacements? Yes. But if there's a tipping point in the decision-making process, I would just say from my perspective, I know a total knee replacement is a more durable option that kind of gets a patient right to what they need if they've really worn more than one compartment.
Okay.
I could speak to that a little bit. I think,
as
Dr. Olson has said, I think, and quite well, at the end of the day, when you're on the fence between a partial and a total, I would err towards the total knee, just from the standpoint of outcomes. You don't want to do an operation that might fail in 5 to 7 years, where you have an operation that could last 25 to 30. I think there's factors that we look at. Obviously, patient age. You might be more willing to do a partial, as Dr. Henry alluded, whether that's patellofemoral or one of the side compartments of the knee, if they're 35 or 40, than you would be if they're 75. That is not to say we won't do partial knees in people that are 75, because if that's what's the right operation, that's a wonderful surgery for them. But when we look at the outcomes and how people do long-term, total knee is still the gold standard that we have to compare to. And so when I have that conversation with a patient, I want to make sure they understand that sometimes, as we're going to the surgery, it looks like a partial, but we make that final determination when we're actually able to look at the other parts of the knee.
Okay. That's great information. I thank you all for sharing. Dr. Olson, one last question for you for a little bit. What are some of the most common questions patients ask when deciding whether or not to undergo either type of knee surgery? What do they ask you?
Well, I think the life expectancy issue is a big one. Most of our patients kind of fall in that 50, 60, 70 year range. And, what they're really asking is, could this be the last surgery on my knee? And so that's a big one. And then the other thing is, a lot of patients have suffered for, extensive period of time that their other knee is suffering. And kind of what I see is a lot of times the other knee that's actually more painful because it's been protecting the arthritic knee still has good cartilage, has good tread, so to speak, that could survive a long period of time. And a lot of times I'm talking to patients about either doing, both knees or one knee. And, when we get into the argument about one knee, a pattern that I see so often is that if you save the worst knee and do a replacement, then you're actually protecting that other knee that's all been doing double duty for a long period of time. And what really surprises me is patients will say, well, how soon can I have the other knee done, doctor? 6 weeks, 3 months. But a lot of these patients do not come back for 5, 6 years or so, essentially saying, hey, my knee replacement's doing well. And yes, the other knee has finally got bad enough where I've decided from my experience as a patient, I'm ready to have it. And I find that very surprising. And that seems to be a discussion and a topic that, at least with my patients, we're talking about an awful lot nowadays.
Okay. Thank you. Dr. Henry, what do you tell patients to calm any concerns or fears they may have regarding knee surgery?
Yeah, that's a great question. But I just want to make a quick comment, since I was just thinking there's been a lot of really good pearls so far. I hope our audience can appreciate this, but this is a really kind of a neat format, and I think a lot of valuable information for a very common condition, and something that a lot of individuals have to deal with and sort out the pros and cons of their decision-making process. And to address your question, Femi, it's really important for patients to know that they're in charge. They're coming to see us for our advice and opinion, recommendation, and help through the process. But they're in charge of their healthcare. We're going to help to figure out what the problem is and weigh out the pros and cons of their decision options. And many times there's not an absolute right or wrong answer. There are pros and cons that will help to guide them through that process. But another thing is that we're treating individuals, and like Dr. Olson alluded to, our care, our philosophy for the three of us here, all of us in our office, it's to customize patient care and to help patients get their quality of life back. Really, the goal of any treatment, whether it's taking an ibuprofen or having knee replacement, the goal is to help patients get back and maintain their desired quality of life, of which they're the important judge. So we're not treating an X-ray, we're treating an individual, and the care is individualized. And I think that's the most important thing for patients to understand, especially when it comes to some of the fears involved in surgery. The other thing that they need to know, which is the philosophy of our office, is that we're a team. We're going to not just perform a surgery and then tell the patient, good luck with your new knee. We're going to give them the best care possible and guide them through the whole process. And if they have questions, we're here to answer it, and we're going to put them in the best hands for rehab and help manage their pain as best possible. And we've got a great anesthesia team at the hospital, and everybody involved in the care is going to be working towards that same goal of helping them to get their quality of life back as quickly and safely as possible.
Okay. I know that today we're talking about surgery, but for knee pain, there are non-surgical options, correct? I mean, I don't present to you with, oh, my knee hurts, and you're like, oh, that's total knee replacement right there, right?
Sign them up.
Very rarely.
Okay. All right. Well, thank you for all your expertise, doctors. If you're just joining us, we're here with Dr. Jon Henry, Dr. Carl DiRaimondo, and Dr. Craig Olson. All three doctors are orthopedic surgeons with Orthopedics and Sports Medicine BayCare Clinic in Manitowoc. We're hosting this Q&A type session focused on partial knee replacement and total knee replacement. Now, gentlemen, I've got another round of questions for you. Dr. DiRaimondo, we'll start with you. Talk a little bit more detail about what a patient can expect prior to his or her surgical procedure. So you schedule the surgery. What do you tell your patient in order to prep them for surgery?
Well, there's several things, and probably something that's become more and more paramount, and we talk about this with our patients. We need to have them optimized medically. Most of these patients, they're older, they have other medical conditions for which they're seeing, their medical doctors for, but it's very, very, very important that we optimize them medically, whether in any controllable factor, for example, diabetes, which is a blood sugar disorder, we need that well controlled. Other conditions, whether it's smoking, we want them to stop. Anything that might impair healing, it's very critical. And all the studies have shown us that outcomes, how they do, cost, recurrent operations, all that stuff is minimized if we can optimize them medically. As was alluded to already, we actually have a class. We are now under COVID, it's more online, but eventually hopefully we'll have it back in person, where patients and their significant others will attend a class, and there's often other patients there, and we're explaining to them the process, what's going to happen at the hospital. We have information on what they can do to prepare their home, exercises. So they kind of come in already with a lot of their questions answered. That is not to say patients don't have anxieties come the day of surgery, but a lot of the things that they would have otherwise not understood or wouldn't be prepared for, we prepare them beforehand. So that by the time they come to their final pre-op visit, we have a medically optimized, they have a pretty good understanding and information and resources to help understand the process, so that when we actually do that operation, and now, as I say, we're on the other side, and now it's, the bulk of this is now on their shoulders.
Right.
They know what to expect and they're ready to go.
Okay. What about during the procedure? What can your patients expect? Or is it nothing because they're asleep?
I always tell patients wheels into wheels out. It's probably a 90-minute deal. The surgery takes about an hour. Typically with modern anesthesia techniques, the vast majority of these surgeries are done under what we call regional or spinal anesthesia. So the patients are numb from their belly buttons to their toes, but they're given medicine so that they don't feel or remember anything. So a lot of it is they wheel in, they're talking to us saying, I'm going to remember this, but they don't remember anything. And obviously we're efficient in the OR. We understand that being efficient and doing things with an experienced team, and we have experienced team of techs and nurses that do joint replacement all the time, we get the best outcomes. From surgery, they go to the recovery, and then we have a couple pathways, either going home that day, which is a smaller group, but it's becoming more popular, or one night stay where you're seeing therapy, but you're out the next day.
Okay. So talk a little bit about the replacement joints themselves. What are they made of? What kind of material is this?
Yep. So I mentioned metal and plastic. So the metals typically are alloys of cobalt, chrome, steel. And if you look at it, it looks like a polished mirror. We also use titanium, depending on, if you're looking at this image, there's the dark black you see on the left image. The upper dark black, that's the thigh bone or femur. That's typically the steel alloy because it's polished, it's shiny, it's smooth. The more flat, which is the lower black image, that can be a different metal, but it's often something a titanium-like, and it's just better for that particular spot. But then there's a gap between the two dark objects, and that's the plastic or polyethylene. Okay. And about, I would say mid-2000s, late 2000s, there was kind of a breakthrough in the science behind manufacturing the plastics for joint replacement, knee, hip, and shoulder. That really reduced the wear and improves the longevity. So when we, patients, and Dr. Olson alluded to, hey, doctor, how long will it last? There's data out there from old implants to say 90% survivorship at 20 years. We're certainly hoping we'll see the same 90% survivorship and maybe out to 30 years with some of the materials that we have available from the late 2000s going forward.
Okay. And that was my next question. How long should these materials last? So you're hoping 20, 30 years?
Yep. And certainly we had that discussion earlier that how do you treat it? How do you drive that car? You drive it aggressively, those tires are going to wear out faster than if you drive it responsibly. But it's good to know that the materials that we're working with are more durable to start with.
Okay. So with those materials, I get my knee surgery. It's lasted 15 years or so. Am I expected to undergo some sort of maintenance procedure or an upgrade or something in the future to maintain my knee health, or no?
Well, I think, a lot of it is general physical health, whether it's a joint replacement or just your natural knee. We'd hope they can maintain some level of cardiovascular exercise, trying to maintain, a reasonable body weight. For every pound of body weight, that's 2 to 3 pounds of pressure across the knee. Most of us who do joint replacement will recommend our patients come back every 3 years once we've done the initial surgery. If nothing else, to get an x-ray, make sure they're doing fine. If, the rare occasion there's a problem, we catch it early. The solution may be simpler than catching it late. Sure. So even though if we say 90%, that means there might be 10% that do have a problem, or maybe a material wears out and we have to change that part out at a later date.
Okay. Dr. Olson, in general, what's involved in successful knee surgery recovery?
I think it's been said by my colleagues. It's that understanding that afterwards, a lot of the recovery is really up to the individual. I would just say one thing about arthritis, and I have a knee replacement myself, so, I kind of lived it. But an arthritic knee loves motion when it's arthritic, and a total knee, to be successful, loves motion. And, one of the things I learned from my own experience in the early post-operative period is if I got up and walked, that's when my knee felt the best. So I guess, getting down to all the different things, we want our patients to kind of partner with us to understand what they're doing, to ask questions. We want a course to familiarize themselves with what the process is going to be like, so that they can know what to expect and not be worried about, what it is. We want them to kind of know in advance what they're getting into. I think another very important piece that was alluded to is that the anesthesia that we provide for patients when they wake up comfortable in the recovery room without pain, those patients have the best success. Now, I don't know the papers or the studies, but I've just seen it in my own hands. The patients that wake up in a lot of pain essentially associate the surgery of their knee with pain, and that becomes a problem. So anesthesia, as a group, we really work with our anesthesia colleagues to do what we call multimodal anesthesia, meaning we want to cover as many bases as possible for a patient. And with the real goal is to wake up without that pain, and that their early process of therapy, and when they are getting out of bed, transferring to a chair within a couple hours, that there's not the pain response that they're fearful of. And I think that's, from a psychological standpoint, that's probably one of the most important things we can do for our patients immediately after surgery, because that sets the table for them to continue on.
Right. Let's stick with that post-surgical potential pain. What about any potential swelling, drainage, or lingering pain? Is that common? And how do you monitor and then address that?
Well, yes. The swelling of the knee is really the barometer that says the bad weather's coming, so to speak. And so we want to control the swelling, because we know that gives quite a bit of pain relief, even before surgery and after surgery. So compression is important. We like to put kind of long-term dressings on, that the dressing removes the moisture that the wound may produce, because we know kind of a wound that's constantly moist is probably not the healthiest. So we use special dressings that are inclusive, so patients can shower early, but also the dressing itself removes kind of that fluid to just reduce the potential of making the wound a little soupy. We want it dry. So we're really addressing the swelling, the wounds, getting the knee moving. I mean, the knee replacement is kind of a unique thing in the sense that we as surgeons are pushing the patients to bend and stretch the skin tissues, which we just recently closed. And then, one of the most important things is intact skin covering a joint replacement, because we don't want that to break down. But yet, it's kind of a miracle in the sense that the wounds are carefully closed so that they can take on all this motion that we want the patients to do without breaking down. And when you sit back and you kind of compare it to a shoulder or a hip replacement, you're like, my God, that knee, look what it does.
Right.
But so swelling, the dressings, the rehab, they all come together, the pain control, all come together as a multimodal method of rehabilitating the patient.
Okay, thank you. Dr. Henry, do patients require any form of home care after knee surgery? And if so, who does that? Is that on the patient? Does your office help with that?
Yeah, that's a good question, Femi. And that's an important part of that pre-surgical individualized evaluation and education process. So we get to know our patients. They go through the joint class, as has been alluded to. and we see what they're going to need. And a lot of times the need for home care can be anticipated and arranged prior to surgery. That's the smoothest. But sometimes it's a decision afterwards, like the day after surgery, as a therapist are working with the individual recovering from knee replacement. It's a need that's brought to attention for home care, whether that's for home nursing to help with dressing changes or to help with showering or other activities of daily living, or for therapy. But there are lots of home services available, and the team approach is the best way. That's a combination of our nursing staff, surgeons, the therapists, both PT, OT, and then the social workers at the hospital are a vital part of that process as well.
Okay, without getting too far in the weeds, has any of that changed dramatically since COVID?
Not the quality of the process. It's just more the way it's carried about. More of it can be by virtual telehealth or telephone calls as opposed to always in person. But the process still happens, and it happens well.
Okay.
And always with the goal of keeping that patient on track for the best possible and safe outcome as possible.
Great, thank you. If you're just joining us, we're here with Dr. Jon Henry, Dr. Carl DiRaimondo, and Dr. Craig Olson. All three doctors are orthopedic surgeons with Orthopedics and Sports Medicine BayCare Clinic in Manitowoc. We're hosting this Q&A type session focused on partial knee replacement and total knee replacement. Doctors, I want to discuss with you the importance of seeking medical care when something doesn't feel right in the knees. Dr. Henry, we'll stay with you. Too many of us just kind of grin and bear it when it comes to any kind of ortho pain. I'm guilty of that as well, including the knees. Why is this ill-advised?
Well, if there's a problem in the knee, for example, that is to the extent of compromising quality of life, and I keep coming back to that term or that issue of quality of life, because that's really the best way to make a treatment decision, then it should be looked into. That's the time to go see your doctor and get it checked out and go through the necessary process to figure out what the problem is, and then have the conversation what to do about it.
And I'm sure you've had similar conversations with patients, but isn't it often the sentiment that, I had some pain, I put some icy hot on it, I took an Advil, whatever the case may be, and then finally your patient comes in because it's just too much to bear. How do you direct somebody in those situations, and how do you encourage people to not wait until the very last minute to come see you?
Yeah, that's kind of a tough question, because we all perceive pain differently, and that's why treatment should be individualized. But yeah, in general, if someone just has some joint soreness or maybe some pain after activities, that gets better if you take an ibuprofen, or by the next morning it's better and they can carry on with their activities or exercises, that's the kind of pain you can work through. You don't have to necessarily go into the doctor's office or pursue further treatment. But when you have pain that lingers, or mechanical symptoms like painful catching, locking, sharp pain that really gets your attention, joint swelling, those are all signs of not just like a muscle soreness, but signs of a mechanical structural problem. And then that warrants further evaluation. And when it gets to the point of compromising quality of life, that's when you know you got to take care of it.
Right. Okay. Thank you. Dr. DiRaimondo, what's your advice when it comes to any knee health related issues? Pain, stiffness, limited motor function, so on and so forth. What advice do you have for anybody who's experiencing any of that?
Well, I think Dr. Henry's already kind of touched on this, but it's quality of life. If it's causing them enough problems that it affects whether that's work, recreation, or what have you, a lot of times it hurts at night, it keeps me awake, it's worth having that evaluated. I know the discussion today is about partial and total knee replacements, which is the end of the road to a long process where we may have been doing a lot of non-surgical or less invasive surgical procedures to preserve the joint. And understand, we start with all those. I know there's the fear some patients have of, I don't want to have my knee replaced. Well, it may not even need a knee replacement. Most don't when they first come in. And I guess the last thing I would say on that is, if the problem is caught early, it's probably a much simpler fix, whether that's non-surgical or whether that's a joint preservation, such as we're doing a scope of the knee, repairing something versus removing it. If caught late, then we're left with maybe we're just doing injections until the day comes that we do the replacement,
Right.
and it may not give them as high a quality of life, that we could have had if we caught it early.
Right. Thank you. Dr. Olson, can you offer some tips on how best to keep our knees healthy?
Well, I guess respect the fact that when the knee is giving you some of these negative signals that have all been brought up, that either change what you're doing or seek out, some advice. And again, it's been stated by my partners, we have a lot of non-surgical options, and a total knee or a partial knee replacement is usually not the first. I think the thing that is important to know is that the knee joint, in a lot of its functions, sees sometimes 5 to 10 times body weight through the joint. The joint forces are huge. So some things that the knee needs, it needs motion. It certainly needs healthy muscle tone around the knee to guide the knee and control the knee. And, a lot of times it just needs motion when it's hurting, like, stationary biking or walking or swimming. So I guess the thing is respect the knee. The knee really is a big part of the quality of life to keep us moving around and enjoying what we have. And, when the knee is giving negative signals, don't bury your head in the sand. We're here to help. We want to help. And like Dr. DiRaimondo was just saying, a lot of times we can rebuild the normal tissues to keep them well. And, hey, metal and plastic, that's at the end of the bus ride. Maybe you want to get off early and, some of the minor things, get those things stabilized and, get a lot more miles out of that tire.
Okay. Great conversation. Thank you, doctors. Well, let's keep it going a little bit yet. Dr. Henry, all three of you are board certified surgeons. That means you've had additional high-level education. But what does that mean for the care you provide your patients?
Well, it means a lot. We're all a product of our training, but also ongoing education. That's why medicine is a practice, because there's lifelong education, and we all have the commitment that we want to be the very best for our patients. So we want to put our patients in the best hands. And fortunately, and I say this very sincerely, we can offer that right here in Manitowoc.
Sure.
We have an excellent orthopedic team, but we're all committed to lifelong education by going to additional courses and interacting with one another and really working towards the best interests of our patients.
Okay. Dr. DiRaimondo, kind of reiterate for me, how does that educational experience and fellowship training make you even better prepared to treat the conditions that we've discussed today?
Well, I look at what we call residency, which is the training to become an orthopedic surgeon, and then fellowship, which is additional training above and beyond. That was the foundation that we all that established ourselves when we stepped out into practice. The three of us sitting in front of you have over 60 years of orthopedic experience, so understand that. And things we learned and trained on maybe in the 90s and early 2000s, not that there aren't still fundamentals that we're doing. It's evolved significantly. I mean, that's the one thing about orthopedic surgery that I think excites us. There's always, new and different and maybe modifications of what we're doing. So once again, I think the training was a foundation, but as Dr. Henry has alluded to, it's the ongoing education and our Academy of Orthopedic Surgery that provides us with opportunities where every year we're going out and doing courses. We're trying to learn and bring back techniques that we feel in our hands we can provide for our patients, so that we feel that we provide the best quality care, but then also we're also allowing our patients exposure and access to care that maybe historically they wouldn't have been comfortable getting done locally and they would go elsewhere. But having that additional breadth and foundation makes us more comfortable kind of expanding our horizons, shall we say.
Excellent. Excellent. Thank you so much for explaining that. All right, sort of a final question here. If patients are dealing with symptoms that they think might be related to the knee issues that we've discussed today, what should be their best course of action? Dr. Henry.
Well, they can certainly get it checked out. They can start on whatever path they prefer through primary care or with physical therapy. A lot of physical therapy places have direct referrals. And if the evaluation process suggests that there's a problem that needs orthopedic input, then they see us, and then we take them to the next step in the evaluation and treatment process. Often there is a process involved that definitely should be individualized to the patient's needs and their goals for treatment.
I mean, my comment on that is I think obviously some of it depends on the insurance plan and how that works, but understand if there's a knee problem, if there's a shoulder problem, if it's a joint or muscle related issue, you're looking at the experts. We know we oftentimes by coming to us first, provided that's okay with their insurance company, we'll get them to a diagnosis and a treatment plan, I think in a much more efficient fashion, because that's the world we live in. And that's the knowledge we bring to that, problem.
Sure. And basically a question for all three of you. Is there a referral process to see you, or can I just pick up the phone and ask for Dr. Henry or Dr. DiRaimondo or Dr. Olson?
I think
you can pick up the phone. Yeah. Go ahead, Dr. Olson.
You can call at any point, and we have some very skilled people that answer the phone that really can, with just a moment's effort, sort out some of that information based on getting a little bit of information about their insurance.
Good.
But our philosophy here is to get people in and get them seen and figure out the way to do it. So, a lot of people come and see us without referrals, and that's just fine. I mean, our thought is we're trying to be as much available for our patients. We hope that a single phone call can solve all these issues that make healthcare so complicated and really get to the root of what needs to be done for the patient, get them seen, and get them cared for.
Mm-hmm. All right. Thank you so much. Well, we've certainly covered a lot today, but is there anything that any one of you would like to add that maybe we didn't get into?
Technology. Just briefly. I mean, Dr. DiRaimondo, and Dr. Henry have mentioned that there's constant education in practice. And there's a lot of options of new technology that's out there. We kind of, as practitioners, almost have to referee some of that, meaning we need to use some common sense basis to really, know what technology benefits our patients. And sometimes there's a little bit of a gut feeling. I mean, I lean on other practitioners that I know in other parts of the country a lot of the time to get a little bit of information. One of the pieces of technology that I think is really valuable, and I know we all are using it in some way or form, but it's three-dimensional data that we either get from a CT scan or an MRI that starts really giving us customized treatment plans for our patients, in terms of the alignment, the ligament stability. And a lot of this is just moving closer to robotic surgery, which in some ways has me nervous because, as an older surgeon, what am I going to do? I like doing surgery, but the technology's out there, and I think we're all constantly looking at it. We're sounding off of one another with our questions and our thoughts about what it is, so that we can just make sure that we can offer technology that's really going to benefit our patients. And we don't really want to be the first ones doing something that turns out to be a disaster, because we've seen those disasters, unfortunately. But technology is a big deal. This group really, if I could just say it, rocks with technology, because we're always looking forward to see what we can change to improve patients' lives.
Great.
A quick comment on that, if I could.
Please, yes.
because sometimes with new technologies, there's big marketing campaigns, billboards that are promoting new techniques, especially with robotic surgery. And patients can be misled thinking that they're going to have the latest, greatest when there's a compromise for experience. There's no substitute for experience when it comes to quality surgery with successful outcomes. Excellent experience and skills combined with technology gives you the best situation. But you can't replace experience for a shiny new toy or tool.
Sure.
Or the latest technology.
Sure. All right, great. Doctors, we thank you for your time today and for sharing your expertise. And we thank you, our viewers, for joining us. If you have additional questions for Drs. Henry, DiRaimondo, or Olson, please continue to ask them in the comments section. We will continue to answer them online. All three of our doctors are orthopedic surgeons with Orthopedics and Sports Medicine BayCare Clinic in Manitowoc. To learn more about the doctors and their experience, or to request an appointment, please visit baycare.net/ortho. Thank you, and enjoy the rest of your day.
Thank you.